Hello, and welcome to the CAP Today webinar for Tuesday, October 26th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and then moderate a question and answer session after our formal presentation today. Today's webinar is entitled Unlock KRAS G12C for Lung Cancer Treatment Decisions. This very important webinar is made possible by a special educational grant from QIAGEN. I want to acknowledge QIAGEN, and we want to thank them for their help and support in bringing you this important program. We have a single speaker today, and I'll say more about him in due course. He's Dr. Anjen Chenn of Labcorp, works in the Research Triangle Park, and there he is the Discipline Director for Molecular Oncology. As I said, we'll make some more remarks about Dr. Chenn right before he begins. But first, as usual, I want to make a few housekeeping notes. First, I suggest you refresh your browser. That can help keep everything in optimal sync. We do have live aid throughout the webinar today, on the phone and online. On the telephone, you'll see in the bottom right corner of your screen a number for technical support. You can dial 858-345-5916 at any time with technical questions. Below the slide deck, you'll see a box labeled Q&A. You can also alert us about any problems you're having technically by typing into that box. Of course, the question and answer box is principally designed to allow you to make comments and pose questions to our speaker. And you can do that at any time during today's webinar simply by typing it in. And if you have a technical problem, we'll address that immediately. And then with questions and comments on the topic, I'll triage those as we go through. And then, as I mentioned before, lead a question and answer session after Dr. Chenn's presentation. I want you to know that we will post all the slides and audio in about a week, and you can see that at captodayonline.com. You can expect to see a follow-up email, and so I want to let you know that that may well be coming. Finally, it's important, as always, that I tell you CAP Today does not endorse any product or service that may be mentioned in today's webinar. And of course, any remarks that I make are purely personal, not to be taken as policy of the CAP Today or the College of American Pathologists. And now, let me introduce our speaker, as I promised. Dr. Anjen Chenn got his MD and PhD at Stanford. He trained then in pathology at the Brigham and Women's, and is currently the medical director at the Center for Molecular Biology and Pathology. He's the discipline director for Molecular Oncology at Labcorp in the Research Triangle Park. And I'll invite him to begin now. Dr. Chenn.
Great. Thank you, Bob. Again, my name is Anjen Chenn. I am a physician scientist with board certification in molecular genetic pathology and clinical pathology, formerly in academia, now with Labcorp. I would like to thank QIAGEN again for sponsoring the program and the CAP for organizing this webinar. Today's presentation will consist of 3 parts. The first is to discuss KRAS G12C as a key emerging biomarker in non-small cell lung cancer. The second is to introduce Lumacras, a recently approved treatment for non-small cell lung cancer patients with tumors with KRAS G12C mutations. And finally, to review updates to the NCCN Guidelines and introduce the methods for identifying KRAS G12C mutations and the QIAGEN Therascreen KRAS RGQ assay. So just as some background, we'll be talking about non-small cell lung cancer. And from its name, non-small cell lung cancer encompasses any epithelial lung cancer that is not small cell lung cancer. By and large, we're predominantly speaking of adenocarcinomas, squamous cell carcinomas, adenosquamous, large cell carcinomas, as well as certain less common other varieties of lung cancer. Non-small cell lung cancer comprises around 85% of all lung cancer cases. They're primarily caused by smoking, and they are relatively insensitive to chemotherapy compared to small cell carcinoma. In this country, the incidence of non-small cell lung cancer has been declining, thought to be largely due to tobacco control programs. Comparison of data for mortality with the incidence of non-small cell lung cancer shows that mortality recently has been decreasing even faster than the incidence. This decrease was associated with improvements in survival, and the timing of the decrease corresponded with the emergence of targeted therapy. In other words, therapy targeted to the changes that drive the growth and survival of non-small cell lung cancer cells. So in these graphs, in 2003, the first targeted therapy to EGFR mutations, gefitinib, was approved by the FDA in this country. And in 2013, you can see that EGFR-directed first-line therapies were approved by the FDA and associated with a corresponding decrease in mortality. The emergence of targeted therapies for non-small cell lung cancer have improved survival. This figure shows the differences in survival of patients treated with therapy targeted to oncogenic driver mutations in the yellow line, compared with the survival of patients who did not receive targeted therapy in the dark blue line, or patients who had no identified driver mutations in the light blue. Despite these advances, prognosis in patients with advanced non-small cell lung cancer remains grim. Only 6 to 20% of patients receiving second or subsequent lines of therapy have a response. And of patients treated with chemotherapy or checkpoint inhibitors, the median progression-free survival is only 2 to 4 months. So obviously, what else can be done? This challenge leads to our first topic for today, to discuss KRAS G12C as a key emerging biomarker in non-small cell lung cancer. The RAS oncogenes, KRAS, HRAS, and NRAS, are the most frequently mutated oncogenes in human cancer, and have therefore been of great interest in targeting for therapeutic development. The arrows highlight the mutation frequency of KRAS in adenocarcinoma and squamous cell lung cancer. Activating mutations in KRAS are the most common driver mutation in non-small cell lung cancer. Approximately 25 to 30% of cases have activating mutations in KRAS. Standard treatment options until recently provided only modest clinical benefit. So as a background, the KRAS protein is integral to cell growth and proliferation, and it is a key part of the RAS MAP kinase pathway. The KRAS protein is a GTPase, a guanosine triphosphatase, that functions as a molecular switch, cycling from an active GTP-bound form and an inactive GDP-bound form in response to extracellular stimuli. The active form stimulates downstream signaling pathways via MEK, MAP kinase, and MYC to affect gene expression changes that lead to cell growth and survival. When the GTP is hydrolyzed to GDP, the protein is switched to an inactive state. KRAS G12 mutations interfere with GTP hydrolysis. So these mutations in KRAS that favor the active GTP-bound form lead to hyperactivation of the signaling pathway and uncontrolled cell growth and independence from extracellular signaling stimulation. The KRAS G12C itself results from a single nucleotide change at codon 12, leading to a substitution of the cysteine for a glycine amino acid. The KRAS G12C mutation thus results in a hyperactive protein that favors the GTP-bound state. KRAS G12C is the most frequent variant found in non-small cell lung cancer, around 13%. These are about 40% of all KRAS mutations in non-small cell lung cancer. And again, these are also associated with smoking. KRAS mutations are prognostic in non-small cell lung cancer. The presence of KRAS mutations is prognostic of poor survival when compared to wild-type KRAS, independent of therapy. And also, KRAS mutations predict lack of benefit from EGFR tyrosine kinase inhibitor therapy. Unfortunately, KRAS mutations have long been considered undruggable, and this is because of the observations that KRAS protein has a high affinity for GTP, and the observation that GTP is present at high intracellular concentrations. The apparent lack of binding pockets on GDP-bound KRAS for a drug to bind and stabilize led to long-standing pessimism about KRAS being a druggable target. So this leads to the second part of today's presentation, which will provide an introduction to a new drug that targets specifically the KRAS G12C mutations, and this is called Lumacras. Several breakthrough structural and mechanistic studies set the conceptual foundation for the clinical development of covalent and selective KRAS inhibitors. Sodorasib is a small molecule developed by the pharmaceutical company Amgen that specifically and irreversibly targets KRAS G12C. Sodorasib covalently binds to a pocket of what's called the switch II region that is present only in the inactive GDP-bound conformation. It, in fact, binds to the cysteine that is present only in G12C mutated KRAS. And when it binds, it traps KRAS G12C in the inactive state and inhibits KRAS oncogenic signaling. So this is obviously very promising. And what does it do for patients? Well, Sodorasib showed clinical benefit for non-small cell lung cancer patients who harbored the KRAS G12C mutation. The CodeBreak 100 was a multi-center, single-group, open-label, phase 2 trial to evaluate the efficacy and safety of Sodorasib as monotherapy in patients with locally advanced or metastatic KRAS G12C mutated non-small cell lung cancer. The key inclusion criteria for this trial were age 18 years or older, pathologically documented locally advanced or metastatic non-small cell lung cancer with the KRAS G12C mutation confirmed on central lab testing with the use of the Therascreen KRAS RGQ PCR Kit. And this is the assay that we'll be discussing later in this talk. The patients had disease progression after the receipt of anti-PD-1 or anti-PD-L1 immunotherapy or platinum-based combination chemotherapy, or after the receipt of both immunotherapy and platinum-based combination chemotherapy. In this study, 124 patients were enrolled whose disease had progressed on or after these systemic therapies. The primary endpoint was objective response, complete or partial response as assessed by blinded independent central radiological review. The tumor response was assessed by independent central review according to RECIST version 1 with the use of contrast-enhanced CT or MRI imaging. Among the 124 patients who were evaluated for a response, 4 or 3.2% had a complete response, 42 or 33.9% had a partial response. Thus, an objective response occurred in 46 patients or 37.1%. And this panel shows the best percentage decrease from baseline in the tumor burden, which is defined as the sum of the longest diameters of all target lesions in these patients. In summary, the tumor shrinkage and disease control was observed in the majority of patients enrolled in the study. Let me step forward here. And these panels, panel C shows the Kaplan-Meier curves of progression-free survival among all 124 patients, and panel D shows the overall survival amongst the patients enrolled in the trial. Just to summarize, the median progression-free survival was 6.8 months. The median duration of response was 11.1 months, and the median overall survival was 12.5 months. The therapy was well tolerated. Grade 4 adverse events related to treatment were noted in 1 patient, and grade 3 events were noted in 25 patients. The study itself was small. It had some limitations. Number 1, the effects of Sodorasib were not compared in a randomized clinical trial. It was not investigated whether combination of Sodorasib and other therapies would improve outcomes. And first-line usage of Sodorasib was not investigated. But based on the study, the FDA granted accelerated approval for Sodorasib. This is cut and pasted from the package insert, but just to summarize, the highly selective and irreversible KRAS inhibitor, Sodorasib, showed clinical efficacy with reversible toxic effects, mainly of grade 1 or 2. An objective response was observed again in 37% of patients with a median duration of 11.1 months, and the median progression-free survival was 6.8 months with median overall survival of 12.5 months. These data provide further evidence in support of the clinical use of Sodorasib in patients with G12 mutated KRAS non-small cell lung cancer. In light of these clinical data, the NCCN Guidelines for molecular testing in non-small cell lung cancer were updated, leading to the third part of today's presentation. So we'd like to review the principles of molecular and biomarker analysis in non-small cell lung cancer because, as you know, they're rapidly changing. In general, let's cover the ideas of what to test for, who to test, and when to test.
Thank you, Dr. Chen. This is Bob again. I'm going to take you through our first polling question, and then Dr. Chen can resume. The question, of course, do you currently test for the G12C mutation? You see the yes and then the no. You also have a chance to show us which test, if any, that you use in poll 1A and poll 1B. If yes, which test? If no, why not? I'll give you a chance to fill all 3 of those questions out. There you are. Very good. You can see we still have a good test adoption here. And with that, I will close this poll out and ask Dr. Chen to go ahead and resume his talk.
Great, thanks. Historically, the utility of KRAS testing in non-small cell lung cancer has been motivated by its prognostic value, and also that KRAS activating mutations have been observed to have a low probability of overlap with other targetable mutations. And this is something we teach to our medical students, that having a KRAS mutation is mutually exclusive to the other driver mutations in non-small cell lung cancer. And also, because of this finding, the presence of a known activating mutation in KRAS can identify patients who would be unlikely to benefit from further molecular testing. However, now with the approval of Sodorasib, KRAS joins a growing list of actionable biomarkers in non-small cell lung cancer. So the NCCN recommendations for molecular testing are guided by the idea that testing should occur for actionable biomarkers. And again, one thing we continually hammer into our trainees is that don't order a test if you don't have a plan to do something about the result. So with regard to actionable biomarkers, in early stage lung cancer, EGFR mutation testing is recommended by the NCCN for guiding the usage of osimertinib, or otherwise known by its brand name Tagrisso, as adjuvant therapy. In late stage 3 to 4 lung cancer, KRAS joins EGFR and other biomarkers that drive treatment decisions. The NCCN strongly recommends broad-based testing in addition to single analyte testing to improve the efficiency of tissue utilization. Again, this is clipped directly from the most recent NCCN guidelines on KRAS testing. And you can see now both in histological subtypes in the top row, adenocarcinoma, large cell, non-small cell, and otherwise, as well as in squamous cell carcinoma, KRAS is now included in the recommendations for molecular testing. And just for a note for the non-anatomic pathologists in the audience, why test squamous cell lung cancer? Well, due to sampling issues, it is impossible really to rule out an adeno component in squamous cell tissue samples. And secondly, the positivity for these various markers has been observed in squamous cell cancers as well. So the current recommendations are to test all non-small cell lung cancers, squamous or adeno, irregardless. So to review the NCCN guidelines on KRAS testing in non-small cell lung cancer, what to test for? If a targetable oncogenic driver is detected, then targeted therapy is typically the best option. And now that KRAS G12C is now actionable, KRAS G12C should be part of your testing menu. Who to test? With regard to KRAS, at least, all patients with newly diagnosed stage 4 disease or locally advanced stage 3 disease should be tested. And when to test? Now, again, the NCCN recommends strongly that testing occur at initial diagnosis as quickly as possible. And this is due to tissue and logistical and reflex testing challenges associated with just the hands-on aspect of testing tissue. Many molecular labs are not fully well equipped to handle the logistical aspects of downstream testing in a reflex manner. So in general, if you have the tissue, you should test all of it at once as quickly as possible. Part of the motivation for recommending immediate testing and immediate and broad testing is from a recent survey from the CAP that shows that biomarker testing is still underutilized. Now, this occurred before KRAS was incorporated into the list of recommended biomarkers to test, but in this list, only 7% of respondents tested for all relevant biomarkers. So again, to review treatment guidelines in KRAS G12C mutant positive patients, Sodorasib is indicated for locally advanced or metastatic non-small cell lung cancer. It's indicated for treatment of adults with G12C mutations who have received at least one prior systemic therapy. The patients enrolled in the CodeBreak trial were identified as KRAS G12C mutation containing patients using the QIAGEN Therascreen assay. And this is what we'll be talking about in the next part of the presentation. Along with the approval for LUMAKRAS or Sodorasib, the FDA also approved the QIAGEN Therascreen KRAS RGQ PCR Kit as a companion diagnostic assay. This PCR kit is the FDA-approved tissue companion diagnostic for non-small cell lung cancer for KRAS and is the only approved companion diagnostic test to support identification of patients for treatment with Sodorasib using formalin-fixed paraffin-embedded tissue sample testing. Now, this is the intended use statement in the KRAS kit itself. Again, the KRAS Fairscreen RGQ test was already an approved companion diagnostic for colorectal cancer to identify KRAS wild-type colorectal cancer patients to determine eligibility for Erbitux and Vectibix therapy. So, following the CodeBreak trial, the indications for usage of this kit were expanded to include non-small cell lung cancer.
Thank you, Dr. Chenn. And now we come to our second polling question. And this will give you a chance to respond. I'm going to read this for you. Would you like to know more about the FDA-approved Therascreen KRAS RGQ PCR Kit as a companion diagnostic for Lumacras? Let's see that filling in. And that's settling out there at about 70 to 30, so 7 out of 10. We'll leave that up just for one more second. The companion diagnostic test that's approved for Lumacras. Okay, very good. We'll take that poll down and ask Dr. Chenn to resume. Dr. Chenn.
Great, thank you. And so we will learn more about the Therascreen KRAS RGQ PCR Kit. Now, this kit targets KRAS specifically. It's a real-time PCR assay. It's a qualitative real-time PCR assay that targets 7 mutations in codon 12 and 13 of the KRAS gene, including, of course, KRAS G12C. It's performed on the Rotogene Q MDX, and software is provided with the instrumentation itself. And again, this is IVD. In other words, it's a FDA-approved companion diagnostic for the indications we previously described. The testing workflow is complete and includes KRAS controls. So you move from sample, which is formalin-fixed paraffin-embedded tissue. Purification components are provided within the kit, and detection is using the real-time qualitative PCR. The software included provides the analysis as well as interpretation. So again, it detects 7 somatic mutations in KRAS codons 12 and 13. and has been validated using clinical studies on colorectal cancer and non-small cell lung cancer tumor samples. And again, in the lower right of the slide are the specific mutations that are detected by this assay. Some of the relevant performance data I am sure many are interested in is the limit of detection, or the percentage of mutant DNA in wild-type DNA that can be detected by this assay. The assay is generally very sensitive for these mutations, and specifically for KRAS G12C, it is able to detect 1.5% mutant DNA in wild-type DNA.
Thank you. And now we come to another polling question, and that's also gauging your curiosity. Would you like to speak to an expert about the Therascreen KRAS RGQ PCR Kit? You can vote now, yes, no, or no vote. I'll leave that up there for another moment. And we see the results coming out here. Would you like to speak to an expert about the Therascreen KRAS PCR Kit? All right, I'll take that poll down now and ask Dr. Chenn to continue once again. Thank you.
Great. We can just go through this quickly. These are just some guidelines as how one would order the Therascreen kit assay if you have identified a patient potentially eligible who has non-small cell lung cancer. Of relevance to the pathologists in the audience, the specimen requirements for the Therascreen KRAS kit are that these need to come from FFPE 5-micron sections. There does need to be a pathologist review for tumor content and determination of relevant area. Sections with less than 20% tumor content will require macro dissection. Sections with less than 4 millimeters squared will require 2 or more sections to increase the tumor area to at least 4 millimeters squared. With regard to stability, the cut slides can be stored at ambient temperature for up to 4 weeks. So to summarize some take-home lessons I hope you have gained from this presentation, KRAS G12C is a new emerging biomarker in non-small cell lung cancer. KRAS itself is the most common driver mutation found in non-small cell lung cancer. Sodorasib, or known by the trade name Lumacras, is the new approved treatment for patients with locally advanced or metastatic non-small cell lung cancer who have received at least one prior systemic therapy with KRAS G12C mutations as determined by an FDA-approved test. Now, the QIAGEN Therascreen KRAS Kit is the FDA-approved companion diagnostic for KRAS G12C from FFPE tissue for non-small cell lung cancer. Testing for KRAS G12C is now part of NCCN Guidelines, and broad testing for all actionable biomarkers is strongly recommended by the NCCN. So I'm glad all of you could join today. Your participation speaks to your commitment in maintaining up-to-date knowledge about emerging biomarkers and laboratory testing in non-small cell lung cancer. And because of this commitment, your patients and your physician colleagues will certainly benefit.
Dr. Chenn, thank you very much for a wonderful presentation on the G12C assay and its importance in determining therapy for non-small cell lung cancer patients. I'll remind the audience we have time for questions, so if you'd like to make a comment or ask a question, please feel free to type into the question and answer box that you see below the slides, and we'll get to those in due course. Dr. Chenn, we have a number of questions here around an order of testing or special algorithms that might be applied for molecular tests useful in diagnosing lung cancer. Tell me, what is your current practice at Labcorp? And obviously, let me ask another one that was in some detail. Would you run a broad optimized panel upon diagnosis, followed perhaps by liquid biopsy? And when would a single gene PCR technology be particularly useful? Could you give us some conversation there? There are quite a few questions along this line, as I'm sure you must receive in your daily practice. Dr. Chenn.
Yes. So I think this is a very hot topic of discussion amongst pathologists and clinicians. As I mentioned, the NCCN strongly recommends what they call broad-based testing upon diagnosis. So following histopathological review, the recommendations by the NCCN are to test for all actionable mutations if possible. Now, they do not really address the question, I think, which many have about what tests to use. And there is always some debate within the profession as to what recommendations we would provide to clinicians and pathologists who might want to send testing to us. Now, at Labcorp, we provide a variety of different options, and we try to discuss with the ordering clinician really what might benefit them the most. Now, I would say that the NCCN favors broad-based testing using primarily, I would say, next-generation sequencing panels for the reason of conserving tissue and for also the reason of providing the broadest coverage not only to the known biomarkers but also emerging biomarkers that do not have clinical approval but may guide a patient towards relevant clinical trials. That being said, if you do not have access to next-generation sequencing technology, or you have strong suspicions about the success possibilities with NGS based on the tissue that you've been able to obtain, then there may be choices that have to be made with regard to what biomarkers to test. I think obviously based on actionability, you may have to make choices amongst EGFR and ALK, ROS, and RET. And this becomes a very difficult clinical decision if you do have choices that you have to make with limiting tissue. With the emergence of liquid biopsies, this may help clinicians who have limiting tissue, and in fact, there are liquid biopsy options for all of the known biomarkers, including KRAS G12C. This is really a bit beyond the scope of this particular presentation, but I think certainly worth future discussion.
Dr. Chenn, thank you. I just want to remind the audience that we are talking about a companion diagnostic that's actually in the drug labeling, and that is an important consideration depending on your institution, depending on the insurance status of your patients, et cetera. I'm sure you'll agree with that, would you not, Dr. Chenn?
Yes, and that is many times what drives the testing that is sent to us here at Labcorp, which we do provide a large host of FDA-approved companion diagnostics. And I would say that, professionally, one of the reasons that may motivate a clinician to order an FDA-approved assay is that there is a certain level of comfort from a clinical and technical performance standpoint that the FDA approval can ensure. As I pointed out, this particular assay was the assay that was used in the CodeBreak trial to identify the patients for enrollment in the trial. And the performance characteristics of this test will not depend on the laboratory that is running the test. Because of the nature of the FDA approval process, one lab that runs the KRAS test should provide the same result as any other lab running this KRAS RGQ test. So there can be a certain level of predictability and comfort that is associated with running a FDA-approved IVD that you may or may not have, depending on the laboratory that you choose to run alternative testing.
Very good. Thank you, Dr. Chenn. And while we don't normally talk much about the approval by insurance carriers, I think it's worth underscoring that insurance carriers will be more likely to approve tests that have been FDA approved, particularly in conjunction with a targeted therapeutic approach. Would you not agree, Dr. Chenn?
Yeah, I would agree with that. And again, as you point out, the language on the package insert for Sodorasib, as well as any of the other targeted mutations, is fairly strong in saying that the identification of the variant of interest needs to be identified with an FDA-approved companion diagnostic test. And this can drive payer decisions.
Yes, thank you very much. I've got one question here of a more technical matter for you, Dr. Chenn. Just speak a little bit about the quality of the DNA that's extracted from the FF formalin-fixed paraffin-embedded tissue and its suitability for the PCR technique.
I would say in practice, because the PCR assay itself requires fairly short amplified fragments, and it is able to detect the mutations that it's been designed for, even with the presence of what would be normally viewed as suboptimal tissue. That being said, I think the limitations are, again, that the fixation should occur without substantial delay after tissue procurement, and the test is not approved for other kinds of fixatives outside of formalin. So in our practice, we have a fairly low failure rate with this assay, as well as other of our real-time PCR assays. They tend to work well because these are, again, from DNA and not RNA, which is notoriously less stable than DNA.
Yes. Thank you very much. And here's a interesting question that I'll pose to you. How fast do the KRAS G12C proteins regenerate? And do you think that continuous inhibition is important to the effective targeting of such proteins?
So that is a good question. I mean, I think part of the mechanism of these irreversible inhibitors is that the KRAS proteins do cycle from the GTP to the GDP inactive form with some rate constant. And the fact that they do cycle is what allows the irreversible inhibitor to access the GDP bound form. As far as how fast, what the half-life of the proteins are is not that clear to I do not have that information at my disposal. So I would say that we, from a practicing standpoint, I think we are bound by the dosing that was established during the trials, and deviating from those dosing recommendations, I would say not recommend unless there was some compelling purpose in an investigational study.
Very good. Thank you very much. Clearly, we're very much on the edge of practice at the moment. Let me ask you one more question, again around this question of mutations. Can patients demonstrate mutations both in the KRAS and have also an ALK mutation in the same sample?
In our practice, we have not encountered any with both. I think the general party line is that KRAS and other actionable mutations have been viewed as mutually exclusive. So I think that would be our party line, but that is not to say that it can't happen.
Very good. Very good. Thank you very much. Do you end up speaking to many clients about tumor heterogeneity? I know it's a very hot topic. I'd be interested in your views on that and the kind of questions that you might get in your practice.
We have not had much discussion of that, only from the, I would say, from the community. More of the discussion has come from involvement in clinical trials and being able to identify different parts of the tumor for smaller single-cell sort of profiling. And there is certainly evidence from many small solid tumors as well as liquid tumors that demonstrate heterogeneity at a sub-biopsy level. But from a clinical practice standpoint for this assay, as well as our NGS assays that we provide, we identify the region of interest on the slide and take all of it. So we don't really segregate the tumor out into little bits, at least in routine clinical practice.
Very good. Dr. Chenn, thank you very much. And with that, I'm going to give you the last word and begin to wrap up a little bit. I want to thank, of course, Dr. Anjen Chenn. He's given us a magnificent presentation on an important new assay, which is enabling patients to receive a very important new targeted therapeutic. I want to thank QIAGEN for their educational grant that has helped to bring us this wonderful program today. Let me remind you that we will be posting the audio and the slides in about a week at captodayonline.com. Finally, I want to thank all of you who've taken your time out of your very busy day and given us your great undivided attention for this magnificent webinar and presentation from Dr. Chenn. I'm very, very grateful for your attendance and hope to see you all again soon. So once again, as I wrap up, I want to thank Dr. Chenn from Labcorp. I want to thank QIAGEN. I want to thank all of you who have attended today. And with that, I'll bring today's webinar to a close. Thank you all.